Good morning to all of you. Uh, it's a great pleasure to address you on this important topic of de-resuscitation. Let me start by thanking the organizers, especially Dr. Shamsad Begum and her colleagues, for inviting me to this really well conducted, fantastic conference. I also want to thank them for giving me a welcome respite of 2 days from the Brahmapuram caustic smog. And also, I would like to say that this is a topic given to me by Srijit. And if at all I happen to confuse you all, you can blame Srijit, not me. So the topic is de-resuscitation. I take you to almost a decade back to this wonderful journal article from Horst and Jean-Louis Vincent and Joseph Kellam and MIDKON, where they actually proposed 4 phases of intravenous fluid therapy as a conceptual model. They said you can start with a rescue resuscitation and go on, which will last maybe minutes or few hours, and then go on to optimization, which should be done in about hours, and then a stabilization phase of days and a de-escalation of about weeks. They were working for the Acute Dialysis Quality Initiative group, and then they said this is a method that can be used, and then called it ROST. That's the acronym they gave up. But almost at the same time, in 2014, Manu Malbran and Paul Merrick, working for International Fluid Academy, came out with this review about fluid overload and de-resuscitation and outcomes in critical ill patients. They came out with this, again, 4-phase therapy that is starting with resuscitation, optimization, stabilization, and evacuation. Evacuation phase with a focus on organ recovery and resolving of the fluid overload that happens in these patients with active late goal directed fluid removal and achieving a negative fluid balance. Now, we all knew for quite some time there is positive fluid balance happening in these patients, especially patients who come with sepsis, burns, severe injuries, and also who undergo major surgical explorations. We know that this positive fluid balance gives us worse morbidity and mortality that has been given to us from multiple studies. It also produces worse overall mortality in critically ill patients, and increased mortality in patients with acute kidney injury was established by the SOAP study. The FACT trial gave us the idea that prolonged recovery in patients in acute lung injury and acute ARDS is produced when you have positive fluid balance. And VAST trial showed us that positive fluid balance produces increased mortality in septic shock patients. We also know that from the colorectal surgery patients that you have worse mortality when you have positive fluid balance. We also know that it produces intra-abdominal hypertension. And in the last decade, the research work into endothelial glycocalyx showed us that EG damage and shedding is produced by increased amount of crystalloid excess and rapid infusion of crystalloids. And they found that actually normal saline produced more problem than isotonic balanced salt chloride poor solutions, and also found that to an extent it is reduced and repaired by albumin or fresh frozen plasma. The fluid overload is what you call it when you have intravascular hypovolemia of more than 10% of the body weight, whereas fluid accumulation denotes a more pathological state of overhydration affecting the entire body. Fluid accumulation is estimated by different methods like change in daily body weight, cumulative fluid balance, or a bioelectrical impedance analysis. It may exist with a concomitant intravascular hypovolemia, normovolemia, or hypovolemia, or may not be associated with the interstitial edema. What is interesting is that new study which came out in 2018 from Reginald Mortel, where he showed that actually almost about 33% of the fluid that accumulates comes from fluid creep, what he called as fluid creep, which is actually pushed to the patient in the form of drug diluent and fluid flush. He also showed that resuscitation, which is usually blamed, actually accounts to only about 6 to 10% of the fluid that is accumulating. The fluid accumulation syndrome describes the presence of any percentage of fluid accumulation with negative impact on end organ function. The end organ function is what is more important when you talk about fluid accumulation syndrome. So you can see the abdominal wall gets tissue edema, renal interstitial edema occurs, hepatic congestion, impaired synthetic function of the liver occurs. You have ascitic formation, gut edema, you have myocardial edema, conduction disturbances, pulmonary edema, and pleural effusion, and sometimes cerebral edema and impaired cognition. When it increases more, what Manu Malbrand thought it is appropriate to call it global increased permeability syndrome, the GIPS. He said the patients who will not transgress to anabolic phase after the F phase and the flow phase spontaneously will remain in the persistent stage of ongoing fluid accumulation, which again he called as the third hit of the shock. This is usually characterized by the high capillary leak index, high extravascular lung water index, and absence of late conservative fluid management from our part, and progression to organ failure. The capillary leak index predicts the outcome of these patients and also improves the control in resuscitation and also will decrease the mortality. CLI is the ratio of CRP over albumin into 100, and this cutoff point of 85.55 was given through some of the research work, and that is supposed to give us best sensibility and specificity as far as the possibility of global increased permeability syndrome is concerned. So coming to de-resuscitation, this is defined by Malbrand and Merrick as the active fluid removal in patients with fluid overload and accumulation using drugs and ultrafiltration. Whereas Jean-Louis Vincent and their group actually defined de-escalation, that is what they proposed, and that they defined as reducing the amount and rate of previously started fluid accumulation. Fluid stewardship is what we should be doing, and that is like antibiotic stewardship. There are 4 Ds, the drug, dose, duration, and de-escalation, and 4 questions, of which 2 are more important as far as de-resuscitation is concerned: when to start and when to stop the fluid removal. That's important. And there are 4 indications and 4 fluid phases, which ends in evacuation, which is de-resuscitation. And when do you start de-resuscitation? Obviously, as soon as the salvage resuscitation has been completed, the goals have been achieved, then you should take a moment and then start stopping the amount of fluid that you're pushing, and then go into a conservative method of fluid management. The aim should be to achieve a zero fluid balance passively as early as possible by decreasing the fluid intake. Look for any evidence of fluid accumulation negatively impacting the organ function at that time. Look for clinical signs like increased weight, positive fluid balance. Look for laboratory parameters of hemodilution. Look for ultrasound signs of BE lines, pleural effusion, low inferior vena cava, collapsibility index, and look for altered cardiopulmonary function. You can look for PLR, that is passive leg raise test, becoming negative. You may see the increased filling pressures. You may see the volumetric preload coming up, and also you will see the absence of fluid responsiveness, which is evidenced by low pulse pressure variation or a low stroke volume variation. You will see increased extravascular lung water index or a failure to lower the EV-LWI. You can also see the markers of organ dysfunction coming up, and you can actually measure the bioelectrical impedance vector analysis, the BIVA, and also use the new VEXA score, that is a venous congestion or excess by point of care ultrasound score, which will give you an indication that you have to start de-resuscitation. So what are the 5 steps that you have to follow? First of all, define a clinical endpoint. That is usually what we take. The clinical endpoint is the improvement in oxygenation, or you can set a fluid balance goal, like 1 liter of negative balance in 24 hours. You can set a perfusion and renal safety precautions. You need that safety precautions, otherwise you may cross the balance, and then you may produce more hypovolemia and then get into more problems. So you will set that perfusion and renal safety lines, like the vasopressor need or the 25% serum creatinine increase. And after every 24 hours, re-evaluate and see whether safety limits have been reached or breached, and adjust the plan accordingly. So you start with preventing. The prevention should involve monitoring extensively. Some of these monitors may not be within your scope, but I like to say that, but that's where research has been done. And why do you need so many monitors? Mainly because none of them are perfect. You can look at the ABP and CVP in case of shock. You need definitely a transthoracic or a transesophageal echo. And you can look at the urea and electrolytes and blood gas analysis and look at the base-excess and lactate levels. You need to assess fluid responsiveness. I think that was told to you in the previous lecture by Dr. SGN. You look at the functional and hemodynamics, the PPV or SVV, and perform a passive leg raising or end expiratory occlusion test. Obtain a baseline body weight, monitor for risk of daily body weight gain, daily and cumulative fluid balance, and you estimate the electrical impedance. And also you assess for the impact of fluid accumulation on end organ function. You can do this by looking at the intra-abdominal pressure, looking at the abdominal perfusion pressure, looking at PF ratios and extravascular lung water index, the pulmonary vascular permeability index, and also looking at the lady SOFA score. You have to metabolically optimize this patient mainly by limiting the fluid intake and limiting the sodium intake, and you have to achieve negative fluid balance while maintaining hemodynamic stability and also maintaining adequate organ functions and also getting the integrity of plasma endothelial glycocalyx possible. Then you can think of an active de-resuscitation using diuretics, applying PEEP to these patients, using a combination of albumin 20% and diuretics, or maybe you can use them all, the pile treatment, that is the PEEP plus albumin plus Lasix treatment, where you use PEEP equal to the intra-abdominal pressure and albumin 20% and Lasix combined given as an infusion. You can use the sustained low efficiency dialysis or with ultrafiltration, or you can use a slow continuous ultrafiltration. You can also use the continuous veno-venous hemodialysis with ultrafiltration. All this will make sure that you take adequate amount of fluid removal, and you have to plan this adequate removal of zinc by monitoring these patients every day, every 24 hours. Important thing is to remember that this can go on and produce more problems like hypovolemia. So you have to know when to stop the de-resuscitation. When do you do that? When the goal is met, obviously, and when the benefit has been achieved, or when the safety concerns arise. And the goal, remember that none of these valid markers none of them are perfect. So you have to have a combination of the markers, and the dynamic markers are definitely better than the static. The fluid-related marker is definitely the neutral balance. You would like to have a neutral balance, and physiologically, you can look at the CVP, PAOP, PPV, SVV, PLR, global end-diastolic volume index, left ventricular end-diastolic area index, or right ventricular end-diastolic volume index. All these are markers you can get by using the some of the new the monitors that are available, and also the echocardiogram that is available. And clinically, you should look at the improved oxygenation by looking at the PaO2, FaO2, and if you have been able to extubate this patient, you know that you are going in the right way. Summarizing, I would like to show you that you can go through this in a fashion of rescuing this patient. Okay, using the rescue algorithm and then resuscitating these patients initially in the early phases by early adequate fluid management. The surviving sepsis campaign actually told us to use 30 ml per kilogram per hour in the initial hour. This may be a bit too much, and then you may actually go on to a fluid challenge of 4 ml per kg in 10 to 15 minutes, and you can use many of these challenges rather than go on to a 30 ml per kg per hour. That way you can use a early adequate fluid management and then go on to optimization, the goal being an organ rescue, where you can start using a conservative fluid management, avoid fluid overload and fluid creep, and aim for a negative neutral balance at that particular time. And the stabilization phase that comes in after about 1 or 2 days, and at that time your aim should be to support the organ, make sure that you get the homeostasis. You can do this by late conservative fluid management. The idea is to get at least 2 consecutive days of negative fluid balance in the first week. Then the last phase, the evacuation, where the idea is to get the organ recovery and resolve the fluid accumulation. This you manage by a late goal-directed fluid removal, which is on the basis of the methods of fluid removal that I've already given to you. The idea is to have an active fluid removal and achieve a negative fluid balance. And once you achieve that, you can be sure that you have at least saved this patient from the effect of global effect of fluid accumulation. There have been a randomized controlled trial which was done in about 2021. The results came out in 2022, and they actually looked at the feasibility of conservative fluid administration and de-resuscitation compared with the usual care in the critical illness setting. The study was inconclusive, although they showed that the strategy actually was feasible and reduces fluid balance compared to the usual care. They also showed that it may not cause any benefit of harm, definitely. So all I want to bring to you is the fact that you want to get a fluid optimized. That is what we want to do. You want to reach that sweet spot, the spot where it lies between dry state and wet state, slightly on the dry side or slightly on the wet side, depending on the situation you are in. And that's the only way to reduce the perioperative morbidity risk, and that can be done by adequate amount of fluid, or rather the substitutive amount of fluid. And remember that fluids are drugs and they should be managed according to the principles of fluid stewardship, and that's the only way you can manage. Thank you.
Thank you very much, Vinodan sir. It was an excellent topic about de-resuscitation. So, of lately, this topic has come into more importance, especially in terms of the intensive care management, and even for the postgraduate students, it's an important topic. We often see this patients resuscitated and they become hypovolemic, and we start the de-escalation. So I just want to know, like, what are the key indicators as ICU doctors we should be looking at when to stop the de-resuscitation phase?
Yeah, that's exactly what we should have in mind. When you start giving fluids, you should think, when will I stop this resuscitation? That's the way you should think about it. When you start resuscitating, pouring fluids into this patient, you should stop, think about, when will I stop? You should have that in your mind. Otherwise, you will be endlessly pouring fluid into this. So think about the time, what benefit you want to achieve. So you have your indexes ready. So if you're looking at the PLR, the passive electrolyzing, which you can do in any of the ICUs without any of the big monitors, then you should be thinking of stopping your resuscitation when the PLR becomes negative. So that should be an easy way of doing it, rather than looking at the more modern monitors. The second thing is, as Dr. Suresh said, we should be having definitely an echocardiogram. That can definitely give you more valuable information. That way, again, you'll be able to know when exactly you reach the level where you can stop resuscitating and start on the de-escalation. Okay. So idea should be to reach the idea should be that your resuscitation should be only for a few hours, if at all, if possible in minutes, or in few hours, and then you turn into a stage of balancing the fluid levels, so that you get into a zero balance stage, and for the next stage onward, you think of negative balance. That's the only way you can reduce the fluid accumulation. Idea is that don't accumulate too much fluid.
And even the de-resuscitation, sometimes we see that we start de-resuscitating and patient go into against the pendulum swinging back into the hypovolemic state.
Yeah, so that is a difficult thing. If you go into it, that's why you prevent fluid accumulation. That should be the idea, so that initially itself you stop your resuscitation fluid as early as possible, go into a zero balance as early as possible, so that you don't have to go to the level of de-resuscitation, which is a difficult task. It's easy to say, but as I showed you, you need many levels of monitoring for you to know that you are not doing harm. Otherwise, you will do more harm by de-resuscitation. That's why the idea in our state, where you don't have so many monitors, the idea should be that you should stop giving more fluids at the time when the benefit has been achieved. That time you should bring down and go back onto your fluid resuscitation, and then give only the adequate amount of fluid, and if possible, start a early conservative fluid management.
Thank you. I would also like to say that what Vinodan sir said and what Suresh sir said is very important. Everyone should at least try and learn the bedside echocardiogram, especially the upcoming anesthetists, because it's very important even in anesthesiology and as well as in the intensive care.
Thank you, sir, for a nice presentation. Audience, any questions? If no, we'll wind up the session. Thank you, sir, once again.